Our learning objectives today: interpret normal and abnormal arterial blood pressure levels in people with spinal cord injuries. There's some unique aspects that we will mention to you. Identify patients who are at most greatest risk for abnormal blood pressure control after spinal cord injury. And specifically, we will talk about two unique conditions. One is autonomic dysreflexia, is a very high level of blood pressure. And another component of abnormal blood pressure control is orthostatic hypertension. Opposite, very low arterial blood pressure developed in these individuals at different stage of their rehabilitation or their life. We talk with you about how to recognize symptoms of this condition, and we also discuss with you what are the present primary clinical recommendations to manage this condition or prevent this condition. And as I mentioned before, if you have patients with Parkinson's disease, with multiple sclerosis, with peripheral neuropathy, you also can see similar situations such as extremely low arterial blood pressure due to orthostatic hypertension in these people, and also people with multiple sclerosis could experience episodes of autonomic dysreflexia. Let's continue. Blood pressure is commonly unstable in people with spinal cord injury. You have to be prepared to deal with this situation, that one day it will be very high, one day it will be very low, and you will not find a typically normal arterial blood pressure in these individuals. More likely, you will see abnormal arterial blood pressure in people with a high level of injury at the high thoracic or cervical level. With the people with tetraplegia, more commonly experiences unstable arterial blood pressure. And the issue is a result that after spinal cord injury, our body losing capacity to either vasoconstrict or vasodilate because there is no normal sympathetic tone coming from the spinal cord to peripheral blood vessels to regulate arterial blood pressure due to our needs. This is reality. And on this slide, we're presenting you data, combination of results of multiple studies around the world where we analyze what is a typical arterial blood pressure in people with different level of spinal cord injury in comparison with able-bodied individuals. You see on part A, when person is supine, arterial blood pressure typically in person with spinal cord injury, particularly with cervical, as you see C, cervical, is very low in comparison with mid-thoracic level of injury or low lumbar region or able-bodied individuals. If person is transferred to seated position, part B on this slide, you see that individuals with cervical spinal cord injury or with high thoracic level of injury drop their blood pressure even further. And this is the first signs of orthostatic hypertension, that with position change, person with spinal cord injury could present with a drop arterial blood pressure and orthostatic hypertension. This is a reality. Another very interesting observation you see on this slide, this is a 24-hour ambulatory blood pressure recording in a person, 45 years old male, with cervical 5, motor complete spinal cord injuries. This is one of the aspects I hope. Also, you have to be aware that we classified people with spinal cord injury on complete or incomplete injury, and we gave them a grade, American Spinal Cord Injury Association impairment scale, A, B, C, and D. A, there is no motor, no sensory function below the level of injury. B, there is a no motor function, but some partial preservation of sensory functions below the level of injury. C and D, there is a partial preservation of motor and sensory function, and actually in the people with AISD, we're actually expecting that person will be quite functional and he or she will be able to even ambulate. This person, as I mentioned to you, has motor complete, sensory incomplete injury at cervical level of injury, tetraplegic. What you can see here, his arterial blood pressure is not normal. Green line showing you our typical understanding of blood pressure, 120/80, and during the day routine and how his day is progressing, he has episodes high and low. And let's go what are the causes of these changes. At 8 a.m., person had bowel routine. Bowel routine in person with spinal cord injury is quite complicated. They have to insert suppositorium. They have to do digital rectal stimulation. Sometimes bowel routine can last up to 2 hours in one person with cervical spinal cord injury. As you can see, this simple procedure resulted in a high elevation arterial blood pressure up to 180, 190 millimeters of mercury, This is a signs, a results, and presentation of autonomic dysreflexia. At 11 a.m., while seated in wheelchair after the lunch, his arterial blood pressure dropped. And this is a combination of orthostatic hypertension, but also postprandial hypotension, hypertension due to blood flow coming to your stomach after the large meal. And it's also commonly observed in the people with spinal cord injury with high level. Then if you look at 10 p.m. or 5 a.m. morning, his arterial blood pressure again suddenly was elevated. And this was as a result of blockage of his urinary bladder catheter when his bladder became distended with urine. Again, as presented with autonomic dysreflexia, and I actually will mention this is a typical one of the triggers for episodes of autonomic dysreflexia over distended bladder or irritated bladder. So to conclude from these examples, this is a very good clinical tools for you to use in your clinical practice, 24 hours blood pressure monitoring in order to see this unstable arterial blood pressure in person with spinal cord injury, and also note very clearly when it's high, when it's low, and what is the causes. I also will highly recommend to use when you're ordering 24 hours blood pressure monitoring assessment, request patients to document very clearly in a piece of paper in his diary what he or she is doing, at what time, and exactly what kind of symptoms they're experiencing. It's help you to determine what's happened during this day. Very important to remember that why we so worry about arterial blood pressure. If blood pressure going outside of the normal limits, and particularly with respect of outside of normal limits of cerebral autoregulation, and you see this diagram very well established in our physiological assessment of people with cerebral vasculature assessment, between 60 millimeters and 150 millimeters of mercury, our cerebral blood flow can be autoregulated. When arterial blood pressure going outside of this limit, brain cannot, vessels cannot sustain autoregulation, and this could result either hypertensive crisis resulting in hemorrhagic stroke, or if arterial blood pressure is very low, then person predisposed to ischemic stroke. That's why this arterial blood pressure we have to keep in mind. And of course, we don't want to see consequences of these issues. That's again, just to summarize, autonomic dysreflexia associated with dangerous spikes of arterial blood pressure, and orthostatic hypertension associated with also dangerous and unpleasant for person with spinal cord injury decrease in arterial blood pressure.